Hello, my name is Christina Deutschba. I'm a pathology resident at the University of Chicago, and I'm pleased to present an interesting case for the International Society of Gynecological Pathologists. So let's get started. The patient is a 34-year-old female with history of symptomatic uterine fibroids. Imaging of her upper abdomen and pelvis revealed an enlarged uterus measuring 17.1 centimeter in greatest dimension, with hypervascular lesions likely representing fibroids. She underwent total hysterectomy and bilateral salpingectomy, and gross examination of the specimen revealed multiple well-defined, white-whorled myometrial nodules ranging in size between 2.3 and 8.0 centimeter in greatest dimension. This is an example of one of those nodules. Histology revealed dilated, ectatic, and staghorn blood vessels, alveolar pattern of edema, hyperchromatic and bizarre appearing nuclei, high power revealed eosinophilic globoid cytoplasm, and macronucleoli surrounded by perinucleolar halos or clearing. In summary, this is a cellular smooth muscle tumor with staghorn blood vessels, cytoplasmic eosinophilic globules, bizarre nuclei, perinucleolar halos or clearing, prominent eosinophilic macronucleoli, and notably there was no necrosis or appreciable mitosis. The differential diagnosis includes leiomyosarcoma, smooth muscle tumor of uncertain malignant potential, also known as STUMP, and leiomyoma, specifically three subtypes: hydropic leiomyoma, leiomyoma with bizarre nuclei, and fumarate hydratase deficient leiomyoma. First, we'll take a look at leiomyosarcoma. To make the diagnosis of this entity, we need marked cytologic atypia or tumor cell necrosis or 10 or more mitoses per 10 high power fields. Smooth muscle tumor of low or uncertain malignant potential falls between leiomyoma and leiomyosarcoma, and there are no strict defined diagnostic criteria for this entity, but the WHO recommends the following. There may be focal, multifocal, or diffuse nuclear atypia with 6 to 9 mitoses per 10 high power field, but there should be no tumor cell necrosis. If tumor cell necrosis is identified, there should be no other worrisome features. If more than 15 mitoses per 10 high power field are observed, there should be no cytologic atypia or tumor cell necrosis in the specimen. In addition, diffuse nuclear atypia and uncertain mitotic count is often seen, but it's due to brisk prominent karyorrhexis. Next, we'll explore the three subtypes of leiomyoma, starting with hydropic leiomyoma. And this entity has a striking zonal watery edema that separates the tumor cells into thin and delicate cords or nests. Leiomyoma with bizarre nuclei has several histological features that include staghorn blood vessels, alveolar pattern of edema, mononucleated or multinucleated bizarre cells with smudged chromatin, and karyorrhectic nuclei. These karyorrhectic nuclei are often mistaken for atypical mitoses, and the cytoplasm exhibits eosinophilic globoid structures. The third entity is fumarate hydratase deficient leiomyoma, and this variant shares numerous histological characteristics with leiomyoma with bizarre nuclei. And the one thing that is observed in this subtype is the loss of fumarate hydratase enzyme in the tissue. This is an example of a leiomyoma that's stained with fumarate hydratase antibody. And as you can tell, all of the tumor cells have a complete loss of fumarate hydratase enzyme. We use the endothelial cells as an internal control to make sure that the staining worked. At this time, I invite you to choose your diagnosis. So the answer is fumarate hydratase deficient leiomyoma. And why are we interested in a variant of a benign entity such as leiomyoma? First, we have to remind ourselves, where does fumarate hydratase enzyme work and why is it important? This is an illustration of the Krebs cycle. And as you can tell, fumarate needs to be transformed into malate in order for the Krebs cycle to complete one turn. So the fumarate hydratase enzyme converts the fumarate into malate. If we have a mutation, either a somatic or germline mutation, the fumarate starts to build up in the cell and starts to exert downstream effects such as succination of cysteine residues and protein and activation of hypoxia-inducible factor 1. We're interested in germline mutation of the enzyme as it is implicated in the hereditary leiomyomatosis and renal cell carcinoma syndrome. This syndrome is inherited in an autosomal dominant fashion and is comprised of three entities: cutaneous leiomyomas that are identified in over 75% of patients with the syndrome, uterine leiomyomas that are diagnosed at an average age of 28 years, and most women undergo some type of a surgical procedure, either myomectomy or total hysterectomy in their 30s. And about 15% of patients with the syndrome develop an aggressive renal cell carcinoma that's diagnosed between the ages of 37 and 44. Therefore, being able to morphologically identify fumarate hydratase deficient leiomyomas can triage a patient for genetic testing and appropriate management if needed. Next, we should explore if IHC is a valuable tool in the diagnosis of fumarate deficient leiomyomas. Elizabeth Chen and her colleagues identified 6 patients that have the HLRCC syndrome and obtained numerous sections from leiomyomas, stained them with the fumarate hydratase antibody. And as you can tell, the results are quite heterogeneous. Only one case showed complete or uniform loss of the enzyme. 3 cases showed heterogeneous expression, and 2 showed uniform retention. So what does that mean for us? It means that if we have a uniform loss, we can definitively diagnose fumarate hydratase deficient leiomyoma. But if we have some type of an expression, we cannot exclude the entity. And this is because there may be a missense mutation in the fumarate hydratase enzyme gene that still produces a protein that can be detected by the IHC. So remember the caveat that fumarate hydratase missense mutations can still produce the FH protein and it can be detected by IHC. Getting back to our patient, at age 34, she underwent total hysterectomy due to leiomyomas. Her mother was diagnosed with some type of a kidney cancer that ultimately metastasized at the age of 59. And there are a couple more family members that underwent total abdominal hysterectomy secondary to fibroids. So the patient decided to undergo genetic testing, and germline testing revealed a fumarate hydratase variant of uncertain significance, and somatic testing showed no additional mutations or copy number alterations. So in summary, why are we interested in recognizing and diagnosing fumarate hydratase deficient leiomyomas, and how do we do it? So at low power, we look for staghorn blood vessels and alveolar pattern of edema. And at high power, we concentrate on cytoplasmic eosinophilic globules, prominent macronucleoli with perinucleolar halos, and we may or may not see bizarre nuclei. It's important to be able to identify these histological features as to avoid the overdiagnosis of stump or leiomyosarcoma. And also it allows us to recommend genetic counseling for the evaluation of HLRCC syndrome.